All right, good morning. We're happy to move on to the next session, welcoming Dr. James. So Dr. James is an associate professor of medicine and genetic medicine and a certified genetic counselor at Johns Hopkins University, where she serves as the research director of the Johns Hopkins Center for Inherited Heart Diseases and the Johns Hopkins ARVC programs. Her research focuses on investigating the interplay of genotype and environmental factors on clinical outcomes of arrhythmogenic cardiomyopathies and on optimizing cardiovascular genetic counseling service delivery and outcomes. Welcome.
Well, thank you, everyone. And I'm going to echo Dominic and just start by saying what a delight it's been to have been welcomed so warmly by the HiRO community. You guys have built something really special, and I've just been so honored and so happy to be part of it the last 2 days. All right. I also really appreciate this opportunity to talk about a subject that I'm really passionate about, close to my heart, the impact of genetic counseling on inherited cardiac care. So yesterday, I talked to you about the work I do as part of my role in the Johns Hopkins ARVC program, which, thanks to Dominic's talk, I just had the opportunity to reflect on, is emblematic, I think, of many elements of a highly functional team. I've been really fortunate. Today, I'm going to talk a little bit more about our broader Center for Inherited Heart Diseases, where I serve as the research director. And just to set the stage, because this will become important later, our Center for Inherited Heart Diseases includes 4 clinical genetic counselors, and then a 5th woman who is both a genetic counselor and a research nurse. Her name's Crystal Tishnell. We've worked together for more than 20 years. And it's in this environment that I'm fortunate enough to be able to pursue genetic counseling research studies. All right, so to start, genetic counseling for heart disease is guideline directed. Guidelines across cardiovascular and genetics organizations recommend genetic counseling. It's to support genetic risk assessment, assist in the consent process, help with test ordering, assure appropriate genetic tests are ordered, facilitate the variant interpretation process, and of course, critically, work with patients and families to offer psychosocial support. This is really different from when I started in this field over 20 years ago, when there were essentially no guidelines supporting our practice. Genetic counseling is particularly strongly recommended in the setting of evaluation of sudden unexplained death, sudden cardiac arrest. But when you dive deep into some of these recommendations, what genetic counseling is supposed to entail is really foggy. Well, this document, which I was part of, says that, okay, genetic counseling includes both information provision and psychosocial support. Good enough. I think we can agree. And that furthermore, appropriate and detailed genetic counseling is recommended. Well, who can argue with that? But if you think about it, what does that mean exactly? Genetic counseling exactly for whom? How? Where exactly in the genetic testing process? And critically, how do we measure success? And I think what this boils down to is asking, really, what genetic counseling service delivery and counseling models optimize our patients' outcomes, patient access, and genetic counseling efficiency in cardiology? And it's on us, fundamentally, as genetic counselors to answer these questions. The cardiology guidelines are not going to do it for us. So what I'd like to make the case for today is we really need a more robust genetic counseling evidence base. This is certainly true across genetic counseling, and there's been a number of papers put out by NSGC making this case. But it's very, very true for us practicing in cardiovascular genetic counseling, which is still a young field. And I think the questions we need to answer break down into 2 categories. So first, what cardiovascular genetic counseling outcomes do we actually impact? And then how do we influence them? Once we figure that out, what genetic counseling service delivery and counseling models maximally optimize these outcomes given our available resources? And I'll spend much of the rest of my next 25 minutes or so talking about the existing evidence and then talking about some research studies we're doing to address these questions. So first, what do we know about the success of what we do? And understanding how we influence outcomes is really critical, right? If we can't measure our outcomes, how can we measure whether changes we make in service delivery are successful or are sending us backwards? Just a reminder, and I think all of us who practice in genetic counseling know this intuitively, that there are multifaceted genetic counseling outcomes that you can consider. So there's, of course, the patient care experience, changes to patients, including psychosocial well-being, patient medical health, patient adherence with clinical recommendations, and of course, family changes. Those might look like cascade testing, for instance. All right, so if I were giving this talk 10 years ago, I would be telling you we have essentially almost no evidence of the impact of cardiovascular genetic counseling. The situation has improved. I've just highlighted a couple of articles that give you a snapshot of some of the work that's going on in the field. So here's a very nice paper published a couple of years ago showing that, yes, the involvement of a genetic counselor facilitates cascade testing. So these were 133 pediatric patients with an isolated bicuspid aortic valve. This is seen at a hospital, I believe in the Midwest. So of the families that happen to be seen by a genetic counselor, 2/3 of first-degree relatives ultimately received cardiovascular screening. When there was no genetic counselor involved, that rate was 40%. So a statistically significant increase when a genetic counselor was involved. Interestingly, there was no difference in knowledge. Families seen by a genetic counselor or not had the same genetic knowledge, and there was a trend toward higher empowerment of those counseled by a genetic counselor. All right, our evidence base has increased enough that a couple of years ago, NSGC commissioned a systematic evidence review of genetic counseling for HCM, which is where some of the earliest work in the impact of cardiovascular genetic counseling on outcomes was done. This was led by your own Susan Christian. So this was glass half full, glass half empty. Glass half full, we had data to look at. Glass half empty, there was certainly not enough data for a meta-analysis. And it became pretty apparent in the systematic evidence review that there was very little consistency in approaches to measuring outcomes. So Susan and her colleagues found that uptake of genetic counseling when offered was relatively high, and that participation in genetic counseling was associated with high patient satisfaction. You see that across specialties really for genetic counseling, some increased perceived personal control and empowerment, and decreased anxiety in patients. But Susan and her colleagues also highlighted that future research is really needed on these outcomes. And indeed, this is probably best done through collaboration by international cardiovascular genetics teams. Coming back to Dominic's team's word, and you'll see where we took that in a couple of minutes. All right, so one thing that NSGC and particularly the cardiovascular community has been working on is an effort to make sure we are all measuring specific outcomes using the same scale in the same way. Susan has done a tremendous amount of work on knowledge and informed choice. I'm going to highlight another outcome that we're trying to align, and that's empowerment. So empowerment is theoretically tied to patients' adaptation, patients' adherence. It's a sense of understanding what's going on and knowing what to do about it. So these are two studies published in the last 5 years that show, these are both pre-post studies, that show that genetic counseling by a genetic counselor increases empowerment on the genetic counseling outcome scale. This is a 24-item Likert scale that's the recommended empowerment measure by NSGC. The study on the left was done by our team. These are patients pre-COVID coming for genetic counseling for an arrhythmogenic cardiomyopathy indication. So you can see pre-counseling, the light gray bar, post-counseling, the dark gray bars, empowerment increases. The second study was from Hannah Eisen and colleagues when she was a student at Indiana. And again, you can see a very similar growth and empowerment, and honestly, very similar scale scores on the GCOS. Which suggests this is a good outcome measure in cardiology for us to use. All right, one thing I didn't show you, in that same study that we did at Johns Hopkins, the pre-post study of people with an arrhythmogenic cardiomyopathy indication coming for genetic counseling, we also looked to see how the increase in empowerment was associated by the patient-reported strength of the Genetic Counselor Client Alliance. This is measured on a scale called the Working Alliance Inventory. And what you can see in the red circle is patients who felt like they had established the best relationship with their genetic counselor experienced the biggest growth in genetic counseling. So the quality of the service we provide, at least as viewed by the patients, matter to the success of genetic counseling. It's also worth considering, particularly in this era, as so many more patients are coming to us with genetic counseling referrals, and we're considering alternative service delivery, which outcomes are closely tied to the genetic counselor-patient interaction? Because I'd argue that genetic counseling outcomes least tied to the quality of the genetic counselor-patient relationship and the nuances of genetic counselor-patient communication are probably those most amenable to service delivery, while outcomes like empowerment that are tied to that relationship are ones that we should probably make sure to retain as goals of one-on-one traditional genetic counseling by a genetic counselor. All right, so I'm going to move on now talking about outcomes. So that's sort of where we stood in terms of what we had. And fortunately, the cardiovascular community of genetic counselors, including Susan, came together and recognized we really needed to improve our evidence base. And so we put together the multi-center cardiovascular outcomes study. This is a multi-center study to measure outcomes. We chose empowerment on the genetic counseling outcome scale, cardiac fear, which we measured on a modified cancer worry scale, cardiac anxiety questionnaire, which actually didn't wind up working very well for a number of our conditions. We were going to just measure pre-post. What do we do? How do we succeed? The second is to identify clinical, demographic, and service delivery characteristics associated with the greatest benefit of cardiovascular genetic counseling. And finally, determine which outcomes are associated with the strength of the Genetic Counselor Client Alliance. All right, so pretty simple study, right? Pre-visit questionnaire, genetic counseling visit, post-visit questionnaire. The post-visit questionnaire was administered before genetic test results ordered at the visit were returned. So that helps you separate the impact of genetic counseling from the impact of genetic testing. All right, so had a 28% response rate, not ideal, but about the best we were going to do for this sort of study. And so the data I'm about to show you reflects 890 pre-post visits by 24 clinical genetic counselors across 8 sites. This is just basically demographics. Our patients were really overwhelmingly highly educated, which reflects sort of a common practice seen really in many of our genetic counseling settings, and 85% of our patients identified as white. All right, half of the patients had come to us for a cardiomyopathy indication of some sort, but there was a heterogeneity of cardiovascular clinical indications. And then I'm going to spend a moment on these service delivery characteristics because they become important in a minute. So in 8.5% of cases, a genetic counseling student was present, but that means they weren't just physically present, sitting in the back of the room observing, that they participated to a certain extent in the session. So many of our sites are affiliated with genetic counseling training programs. Let's see, this study involved 70% of cases seen by telemedicine. Something I didn't tell you was this study was initiated in the fall of 2020. So all the data is essentially during or post-COVID. All right, so what are the results? Well, we do make a difference. Following cardiovascular genetic counseling, empowerment increased, cardiac worry decreased, and there was no change in cardiac anxiety, largely because the scale doesn't work well for some indications, which I'm happy to talk about later. All right, this is just bivariate associations. The things I want to point out are, well, where are we really effective at reducing worry for patients with a channelopathy or arrhythmia indication? Gratifyingly, at least in bivariate analysis, we were particularly effective with patients with the least education. Worry decreased most in our patients who had less than an undergraduate degree. Situation with the empowerment outcome was completely different. You can see demographic and clinical characteristics had really very little association with extent of change in outcome. There were race and ethnicity and the involvement of a genetic counseling student. There were trends for more on that later, but empowerment was again very strongly associated with the strength of the genetic counselor client alliance. Here you can see this is similar to the data I showed you earlier. WAI fourth quartile is the best genetic counselor client relationship as reported by the patient. You can see that those patients experience the biggest growth and empowerment. The WAI has 3 subscales. This was true for all 3 subscales, particularly true for the bond subscale, which was reassuring. All right, this is a linear regression. It is showing us essentially that the extent of change in worry is significantly associated with education, with patients with less education benefiting most, with phenotype, with patients with an arrhythmia indication benefiting most, and with personal history, with our at-risk individuals benefiting most, sort of makes sense. Empowerment, on the other hand, is associated with the strength of the genetic counselor-client relationship. Having a trainee involved leads to less growth and empowerment, which is not shocking, but sort of unfortunate news. And then a really sobering finding here was, at least in this cohort, we were less effective at increasing empowerment in our patients who identified as Black or African-American, African-Canadian. That's work we need to do. All right, this is the same thing I just said in those tables. If you like looking at words instead of numbers, change in worry, sensitive to client education and clinical situation, not associated with the genetic counselor-client relationship, at least as measured by the WAI. Empowerment, extent of change strongly associated with that relationship, particularly the bond subscale. Less growth and empowerment with student counselors, maybe less increase for Black patients. And so we think, at least, this is, or could be, foundational evidence that cardiovascular genetic counseling is indeed associated with improved psychosocial patient metrics, independent from the impact of genetic test results. Empowerment, which is theoretically linked to patient activation and adherence, may be less amenable to genomic medicine models that replace genetic counseling with a counselor. And then finally, in contrast, reduction in worry is insensitive to the genetic counselor-client alliance, heavily dependent on the clinical context and patient education, and therefore this really may be more amenable to other educational interventions. We know there's many ways to teach information. I will say, as a limitation, this data is all from multidisciplinary academic settings. I do not know if you'd see the same results for people who are having genetic counseling virtually sort of offered by genetic testing companies. That data is still to be collected. All right, moving on to the second half. So we've talked about outcomes. Now let's talk about service delivery models. I've had conversations with many of you over the years about whether it's time to re-examine the genetic counseling model from pre-test to post-test. And I know a number of people are working on this. This is, at least in the oncology context, and sometimes in the cardiology context, called mainstreaming. And the idea is really genomic-guided medical management that can impact disease, morbidity, and mortality is increasingly recommended. But yet, culturally, this emphasis still remains on pre-test genetic counseling, at least in terms of day-to-day practice. So we and many others are working on rethinking the model, shifting the main genetic counseling visit from pre-test to post-test. This is not a new idea. Again, this is a study out of Alberta who took HCM patients and substituted the pre-test visit for a webinar. This was successful, accepted by patients, and saved time. This is data from a group of genetic counselors thinking hard about what diseases are amenable to post-test counseling. It's called the CADRA framework. And you can see that all of our cardiovascular indications, which are the red balls, were grouped in those that require less discussion pre-test, more discussion for those with a positive result post-test. And for people with a negative result, do we really need to see them at all post-test? With all this in mind, I was really fortunate to be able to integrate a randomized clinical trial of counseling models within our Center for Inherited Heart Diseases. So we received NIH funding for a 3-arm randomized study to test shifting the primary genetic counseling session post-test. Our aims were to measure the impact of post-test counseling on change in patient empowerment and engagement, patient satisfaction, and psychosocial impact of genetic testing. The hypothesis there is there'll be no difference in arms. And then to compare adherence with medical recommendations 6 months post-counseling and an increase in genetic counseling efficiency in those arms. And those both have data science components to them as well. This is the trial design. Really, the take-home message is that all patients coming to the Center for Inherited Heart Diseases with a genetic testing indication who are adults are offered the opportunity to join this study. Usual care is pre-test genetic counseling appointment, results returned by phone or into the EMR. The efficiency arm replaces pre-test genetic counseling with online video-based tailored genetic education with an optional phone call with a genetic counselor and a post-test genetic counseling appointment. Flipped arm is the same as the efficiency arm, except that phone call is required. I'm going to tell you now, patients hate that required phone call. That arm was developed in order to keep the number of touches between the genetic counselor and the client the same, but that arm is going down. All right, so as part of this study, we developed these pre-test educational videos. And so the videos are tailored to the indication and the type of genetic testing. So there's 4 videos: panel testing for familial hypercholesterolemia, panel testing for cardiomyopathy or arrhythmia, and then family-specific variant testing for those 2 indications. And you can see the pictures of our 4 main clinical genetic counselors here. So that's Brittany Murray, Emily Brown, Becky McClellan, Brianna Rivers. Those are the counselors who frankly said yes to me when I came up with this crazy idea of integrating a clinical trial of genetic counseling processes, completely potentially disrupting the life of our clinic. So Dominic talked about teams. This is my team. I'm really fortunate. All right.
The way to determine if a person has a genetic risk factor is to do genetic testing. First, I'll give you some background information on genes and how they work in our bodies. Cells have an instruction guide or code called DNA. That tells the cells what to do or what to make. DNA is made up of individual units called base pairs, made up of the letters A, T, C, G. We have 3 billion DNA letters that make up our entire instruction guide. Functional units or groups of DNA letters are called genes. We have 2 copies of each gene, 1 from each parent. Genes provide the instructions to make proteins. Proteins are the building blocks of all the parts of your body, including your heart. Genetic testing involves looking for changes or variations in the orders of those DNA letters that might impact the job the gene does. You can think of this like a spell checker checking for spelling errors. This is also called a genetic mutation. We will refer to these as variants throughout your genetic testing process.
All right, so obviously that's just a small clip of a piece of one of those videos. We were fortunate to work with an animator who's a professor in our Art is Applied to Medicine department to work on those. So this entire process of shifting the genetic counseling visit post-test is only going to work if that genetic education goes well. And so, as you might expect, we did a ton of formative evaluation as we developed those videos. So let's see, each of the 4 videos was tested in 2 rounds with both individuals from the relevant support groups of FH Foundation and Hope for ARVC, which is properly Hope for Arrhythmogenic Cardiomyopathy, and also tested with members of the local Baltimore community. And so in that formative evaluation, the mean post-video knowledge was reasonably high, 7.12 out of 8 on this multi-dimensional model of informed choice knowledge scale that Susan has worked on refining. And then fortunately for us, we had these engagement and trust questions. And means for all of the trust questions were 4 out of 5 or higher. So people were feeling confident in the information received in the video to proceed. So that was informative evaluation. None of these people were actually having a test. So this is the interim results. I can't tell you the results of the study. We're 40% enrolled right now, but so far the videos are performing well. Out of the first 96 intervention arms, so either the flipped or efficiency arm participants, most of whom had a panel testing indication, nearly 2/3 had a perfect score on the post-video knowledge assessment, so the relevant MMIC subscale. There was a significant increase in knowledge from pre to post-test. Actually, only 2 efficiency arm participants requested a phone call with a genetic counselor, one of whom wanted to talk about life insurance, which the video brought up, so that was helpful. One of whom wanted to talk about billing, so yeah. And then, like I say, the flipped arm is going down. The average time of our flipped arm phone calls was 1 minute and 41 seconds. So you can imagine these are not very rich pre-test conversations. All right, so I'd love to show you results. Stay tuned, they'll come in 2 years. But I did want to take this opportunity to end this talk really on an open invitation to all of my colleagues here in the cardiovascular genetics community, the physicians who work with them. Join us. This is a really great group of people. The alignment of genetic counseling measures and outcome metrics and how we use this to modify our practice, gosh, it's our responsibility. We have to do this for ourselves. I've mentioned Susan several times. I'm sure she'd be happy to talk to you about the cardiology genetic counseling specific knowledge measures she's developing in partnership with Laura Yates from Australia. Laura and her mentor, Jody Ingalls, are working on a review of cardiovascular genetic counseling outcome measures and maybe ultimately a position statement on the goals of cardiovascular genetic counseling. I didn't have time to cover this today, but we're taking our resequenced videos inpatient. So we are moving those to an inpatient post-test model. We've been fortunate to receive funds from NSGC, specifically to Emily Brown, for an ancillary inpatient study that's using an implementation science framework. And the tagline of our ARVC program is, you know, we call ourselves, we're the promiscuous collaborators. We'll work with anyone who has a good idea. That's how good science gets done. And that's sort of frankly my approach to genetic counseling research as well. So please feel to reach out. I'd love to hear from you. And then thank you. This study truly would not have been possible without this entire cardiovascular genetic counseling community. And I'm excited to share the results with you today.
Thank you so much, Cindy. It's fantastic to hear the work you're continuing to do in this space. I'm going to open up for some questions. Yeah.
It's a great presentation. Thank you. I have a question about, it kind of brings the 2 talks together about the ultimate team structure. Because I think one of my concerns about mainstreaming is it opens the door for pulling the GC out of an embedded clinic. And I think for the efficiencies and time from your perspective, how that pans out and what the optimal team should look like and whether this is always the best. So the other question I would ask is, in the data you had, how many of those families were families of sudden cardiac death versus, you know, other forms of testing, and whether it's one size fits all?
Yeah, so let me answer the second half of that question first. So I didn't spend too much time on the inclusion criteria of the randomized control trial, but families with a sudden death indication are excluded. We do not think those families are appropriate. The nuance of using potentially precious postmortem sample in appropriate genetic testing, the grief, yeah, we excluded those families for all the reason you'd expect. So no, one size doesn't fit all. And in terms of mainstreaming, in my perfect world, the physicians would understand the genetic testing guidelines. We would send them these videos to help the patients get educated as they ordered the test. And then we would receive families with high risk variants of uncertain significance and positive results. In my dream world, that would happen because I think you're right. We certainly do want to bring in patients and families with a new long QT diagnosis, an ARVC diagnosis into our clinic, where genetic counselors can then facilitate appropriate cascade testing, and so on. So that's my perfect model, but I recognize that's very probably location and personnel specific.
Yes, hi. I think I'm really following up on the previous question, because my concern also would be representing inherited cardiac conditions patients with the Canadian SADS Foundation, is that I think it's so important that these patients see a team, and that team is not just the physician, and that's not to undermine the physician, but in fact to enhance the team. And so my concern would be much what Simon expressed, is that if you remove that whole genetic counseling too far away from their clinical experience, then there's some almost sense that my physician is the most important person, and this genetic counseling business is just sort of a supplement. And then if I have any further questions, of course, I'm going to go back to my physician. And I would talk to that concept also with regards to, of course, we're in a crisis in terms of resources within our healthcare systems anyway. But I think to build the team is for the patient. This takes time, it takes money, it takes energy. But patients need to know the go-to with a clinical nurse as well. And because the physician doesn't have time to answer all of these questions that patients have, I think it's important for patients to be educated to recognize the different relationships and the different services that are available to them, and not to rate them in terms of which is most important or who's the most important guy on the team, but getting back to our first speaker and recognizing it's a team. And in fact, the patient's on that team.
Yeah, no, I thank you so much for your comment. That was really helpful, and I appreciate it. Again, probably one thing I didn't go into perhaps enough detail in, even in this model, this study, all these patients have a genetic counseling visit. That this thing starts with a genetic counseling appointment being scheduled. So they see the genetic counselor. It's just coming after the test has been ordered. Well, in the flipped arms. And I think, your comments are well placed. Is this more effective or not? Or are we cutting the genetic counselor out? I hope not, but that's a testable question. It is worth saying, for better or worse, we do have support group organizations. Again, for FH, it's the FH Foundation, the Family Heart Foundation, and some sort of ARBC, DCM, genetic heart disease members on our advisory panel. And honestly, we talked about the whole study development with them from the beginning. But of course, everybody has a different perspective, and yeah, we don't know. As we keep reminding ourselves, it's like, well, this is why we do research, because we do not know the answer to the question. Yeah.
I just want to clarify, I think there's efficiencies by your model.
Yeah.
The idea of videos to address to a group of people with the same theme and so on, I think that's fantastic.
Yeah.
And I think, there will be physicians in the crowd for sure. I think there's so many barriers within the different organizations in terms of achieving perfect models anyway. So I did not mean to criticize.
Oh, yeah.
In fact, I think most of what's being done is terrific. It's just how far away does it get removed? That's a question also, not just a.
Yeah.
So just clarifying.
Yeah, no, thank you so much.
Cindy, that was great. And as ever, you've really beautifully set out the importance of the GC, the key role GCs play in so much of what we do. I think everyone in this room believes it, but we certainly, and I'm sure others, are increasingly struggling with convincing payers and other bureaucracies to believe in this and to buy into this and see this as an essential part of the team and needs to be funded. I'd love to hear if you have any thoughts on that. I think, it's something we're all struggling with, but the evidence you set out here was great. How do we Any thoughts on how we get that to the next level and get people to buy into this?
Oh my goodness, Dominic, that's a difficult question. So let's see. I am finishing 2 years of service on the National Society of Genetic Counselors board. So that's what I chose to do. I'm like, I have experience. I need to share it. But strategically, it's very difficult. So, all right, understanding that I'm speaking to a Canadian audience, I'm not going to go too far into the weeds of this, but a lot of the situation, at least in the United States, which of course where you're practicing, relates to genetic counselors not being yet recognized as CMS providers. Unfortunately, the way CMS is structured is that you need literally, not figuratively, literally an act of Congress to make it happen. NSGC is advocating hard for a bill, but think about what you hear on the headlines in the news about the function of Congress right now. And think about us as genetic counselors paying our dues to a lobbying firm, but nonetheless, we are a small community in a giant country needing to get both houses of Congress to pass or add our stuff to a bill. It is a big problem. And I've probably thought more about that in the last year and a half than I ever wanted to. So that's one piece. I think organizationally, let's see, we have had success at our institution, not in cardiology, admittedly, but in genetics, of doing an end run and making this like, we are the experts in this field. We are building essentially an academic division. It's called the Center for Genetic Counseling. We are bringing in grants. We are so we have actually positioned ourselves reasonably well at Johns Hopkins as like a partner who can, support the overall academic mission. It helps that we have a training program. And so that has been a strategy that works for us. And then there's a whole bunch of time studies that I'm sure you all do, but I can talk about this later. I don't want to bore everybody, but it's it is a real problem.
Thanks, Cindy. I'm going to take the final question. Yeah. It sounds like that last question was talking about the outcome measures that matter to the people who hold the purse strings and the structures. Yeah. Do you have any thoughts on the outcome measures that matter most to the patients? And are we measuring that? What's their perspective?
That is such a great question. I love that idea. There you go. You want to do a research study? Have we asked people what outcome measures matter most? Yes, but perhaps not in as formal a way as we ought. With each of these measures, we've gone through the process, and I know Susan's doing this now, of asking what people think about what is that measure getting at? Is this important to you? But that's been sort of a measure by measure thing. But looking across, it's a great question. I see my colleagues there. Does anyone have a better answer to that than I do? Do you know, has this been done? Yeah, I'm seeing them shaking their heads. There you go. All right. No, it's a great question. Thank you for that.
Thank you so much, Cindy. You've given us a lot to think about and a lot to be proud of the work that we're doing in this field. So thank you for highlighting that today.
All right. And thank you again all for this opportunity. It's been so much fun.